It gives me great pleasure to provide this lecture on neoadjuvant treatments in breast cancer as part of the Rebung Community Nursing Competency Program for Cancer. Rebung is a pilot implementation research program in the Klang Valley to create a pilot cancer early diagnosis ecosystem to inform future rollouts. This program aims to increase our community nurses' capacity and knowledge and create networks between hospital and clinics to support and improve our patients' experience. This is our disclaimer slide from our sponsors. The outline of our lecture today is to understand the multimodality treatments and care pathways for breast cancer. We also want to touch upon the World Health Organization global targets for breast cancer. And then we zoom down to what is neoadjuvant treatments and why neoadjuvant treatments are being done. And then we will complement it with a case study to make our learning easier. There is definitely inequities in breast cancer deaths. As you can see, there are so much differences between high-income countries and lower middle-income countries. You can see in high-income countries, 9 of 10 breast cancer patients will survive. As compared to Malaysia, for example, we would say we are at about 6.7 out of 10 that can survive 5 years. What is the WHO Global Breast Cancer Initiative? This is an initiative to improve survival rates of breast cancer patients and reduce premature mortality from breast cancer. It is made up of 3 pillars and it has 3 targets. And we remember the targets as 60, 60, 80, where 60% of the breast cancer patients are detected at the early stage through Pillar 1, which is health promotion for early detection. The second one is a 60-day diagnosis, where the Pillar 2 expects a timely diagnosis, where public and health worker education and signs and symptoms of early breast cancer, so women are referred to diagnostic services when appropriate. So the 60-day of diagnosis is actually from the entry point into the health system to the completion of the diagnosis, which include evaluation of the clinical history and examination, the imaging, the tissue biopsy, and the pathology report must be completed within 60 days. Pillar 3, or the third target, is 80% completion of treatments, where we know there is multimodality treatments when we talk about breast cancer. So in Pillar 3, we are expected to provide a comprehensive breast cancer management for the patient. So breast cancer treatments are multimodal. So what are they? So there's surgery, there's chemotherapy, there's radiotherapy, hormonal therapy, and then you always hear this word targeted therapies, which you could say that hormonal therapy is also a targeted therapy that targets the hormone receptor, but there are other receptors in the cancer cells that make the treatment very effective in controlling the cancer. So one of it is the HER2 therapy. The drugs are usually called trastuzumab, or in the past, the brand was Herceptin. And then you have the other newer drugs, pertuzumab, TDM1, and many others. And then we also have other drugs like immunotherapy and other CDK5/6 inhibitors that is now currently being used. But we are not going to go into too much details on those treatments. What we are trying to explain here is how you play a role in this pathway that the patients experience. So in the WHO Breast Cancer Health Initiative, it actually explains the care pathway the patient goes through, which then is really under the 3 different pillars and targets that they are targeting for. Okay, so the first one obviously is the patient with symptoms or without symptoms, where patients with symptoms, they will be needing a clinical assessment by a doctor, or if they do not have symptoms at all, they will be undergoing screening. And if is there something detected on screening, then they go on to a diagnostic phase, where we call it the diagnostic interval, where we obtain the definitive diagnosis. So when we talk about definitive diagnosis, the patient undergoes a diagnostic workup, which includes clinical evaluation, imaging, tissue sampling, and of course, the pathology report. And after getting the diagnosis, they then move on into the treatment interval or the pillar 3, where there must be integrated care between the different departments, especially surgery, oncology, and of course supported by other departments like radiology and pathology too. Okay, so this multidisciplinary treatment planning requires all the different people involved, and there are very important data that is required for treatment decisions. The 2 most important ones are biomarker testing as well as cancer staging. So let's move on to looking into the different ones, which I think I've already mentioned. Okay, so let's focus on this one here, because when we talk about adjuvant and neoadjuvant treatments, what we mean is these treatments enhances the surgical treatment. So in the past, curative treatments is usually surgery, and then we enhance those curative treatments with other medications like chemotherapy, and like now we know there are targeted therapies, hormonal therapies, and all this, right? So in the past, when we use the term adjuvant, it really means it's used after surgery. But now we know there is another way of treating cancers where we actually use these treatments before surgery. And this includes the word neoadjuvant treatment. So that is the meaning of neoadjuvant. It just means that this enhancing treatments before surgery is done before surgery. Okay, so if you look at this, through biomarker testing, cancer staging, and with the multidisciplinary treatment planning, then the patients, can be of 3 different types. They could be early stage disease, they could be locally advanced, or they could have metastasis or stage 4 disease. So you can see here that for early and locally advanced, it is almost interchangeable. Either the patient needs surgery first, or the patient needs chemotherapy or targeted therapy first before surgery. So what we want to address here is who would be the people that need to undergo neoadjuvant treatments, because sometimes patients get to see the surgeons first and there is no MDT being carried out. And what happens is that the patient does not get the benefit of having neoadjuvant treatments. So I think as people in the community and us as healthcare providers, we need to explain to all our patients and our family members, in case somehow doctors are now telling them to have chemo first, because this is what is a new way of treating people that has enough evidence to support this practice. So let me go into more detail. What is biomarkers? So breast cancer, there are many subtypes. There are many different types of breast cancer. And sometimes the subtypes is found through genetic tests. Sometimes it's done through just staining the slides that we have in the histopathology lab. So the way that is being classified through the genetic or molecular way, they call it luminal A, luminal B, HER2 positive, as well as triple negative subtypes. So these types of disease can be seen through testing in the normal immunohistochemistry lab. That means the usual lab that we send, pathology lab, they stain the slides to test for ER or estrogen receptor, PR, progesterone receptor, and the HER2 receptor. So you can see from the three types of tests, we can call the subtypes of cancer into three types. One is the hormone receptor positive, where you will find that both ER and PR is positive. It can also be ER positive, PR negative, HER2 negative. Okay, and then we have the HER2 positive group, which could be any ER, any PR, but the HER2 is positive. Okay, and now there's this new entity called HER2 low, because when they do the immunohistochemistry test for HER2, you may find that they classify the HER2 3 plus as the true positive. Okay, the 2 plus is the equivocal, not very sure, is it really positive or negative. But now this is called HER2 low. It's a different entity, and we found that there are other drugs that may respond, that may actually cause response in these HER2 low types of cancers. So watch that space. It's not out really in Malaysia yet, but what we have is, if it's truly HER2 positive, then the treatments may be different. Then the last group is called triple negative, where the three biomarkers, ER, PR, HER2, are negative. So these types of immunohistochemistry results is usually seen, if you look at this, in the most common type is actually the hormone receptor positive, where 73% of all cases are this type. Then you have the triple positive, which is about 10%, where the HER2 the HER2 is actually positive, and the hormone receptor is also positive. Okay, and then you have the HER2 positive tumors, which is only about 5%, and then you have the triple negative, which is about 13%. So there are other things in the histopathology report that might be useful for treatments, like the grade or Ki67, which is a marker of aggressiveness. Okay, and other very important information that the oncologist and the surgeon need to know. So what do we do in Malaysia? So we do have a clinical practice guideline, and it does say here that all triple negative and HER2 positive tumors have increased frequency of PCR response following neoadjuvant chemotherapy in early breast cancer. So what is this PCR? I will explain in a short while. So what we have is a recommendation for all patients that fit criteria with triple negative or HER2 positive, that they should actually think about having neoadjuvant treatment and being recommended it, because we can also enable breast conserving surgery, but benefits and risks need to be discussed with the patient. Okay, and then how about neoadjuvant hormonal treatment? Yes, sometimes we can do it in postmenopausal women who have hormone receptor positive, which are not suitable for chemotherapy. Sometimes we use the hormonal medication. So remember, hormonal medication is usually a tablet. The other neoadjuvant treatments includes chemo, and then sometimes the HER2 treatments, and maybe in the future other targeted treatments. But these treatments are usually given intravenously. Okay, so what is staging? Staging modalities that we use is CT scan, thorax, abdominal, pelvis, or PET, and PET scan or PET scan. So PET scan is a bit expensive, so it may cost about maybe 3 times more than a CT scan, but it is it's almost like not really in the guidelines to use PET scan routinely. But to know the staging, we would prefer it to be done in node positive, as well as those patients who have locally advanced breast cancer. Okay, So staging is very important because remember, in our previous slide, when you have stage 4 disease, surgery is not at all in the first line treatment. Usually we will start off with the systemic treatments like chemo, hormonal, and other types of targeted therapy. So let's go back to this one. Biomarkers and neoadjuvant treatments can be used in the pathway, and therefore we need to be aware of it. And we know again, stage 4 disease, you can see most of the time we don't really do any form of surgery. Okay. Even though you look at the arrow here, it goes to radiotherapy, not necessarily, yeah. So this one actually a bit of mistake from this graph, yeah. But what it means is in distant metastases, we should really make sure we don't aim for any surgery in the first line. Okay, so what is the difference having neoadjuvant or adjuvant chemotherapy? Because in the past, you already have the tumor, you have surgery, and then you have chemo. Unfortunately, you won't know whether the chemo works very much, right? But so far, in terms of whether both of these make any difference to survival, at the moment, there is no difference in survival rates. But because you can see the response from treatment, there are many other benefits of it. So what are the advantages of neoadjuvant therapy? So number one, it enhances surgical option. So from someone who needs a mastectomy, we can downstage the lump and the tumor to make it suitable for lumpectomy or breast conserving surgery. Okay, and then sometimes the axillary surgery we do, we remove about 10 to 20 lymph nodes. We call it axillary dissection that has a higher rate of lymphedema yang tangan bengkak tu. So that risk can be reduced by doing other types of surgery to the armpit lymph nodes like sentinel node biopsy or targeted axillary dissection. So anyway, we don't want to go into too much detail, yeah? So the next advantage is it enables early response assessment. That means we know if, let's say, we give the chemo first, we know whether the chemo works. Can you imagine someone who's had surgery already and have the chemo later? For all you know, that chemo is not going to be really helpful for that patient, right? So what it provides is it permits monitoring of response to therapy at an early stage, and it provides an opportunity to adjust adjuvant treatment depending on the response to the neoadjuvant treatment. So what this really means is you can actually add on more treatments because you know, does this chemo really work? So let's say this treatment has been given, the patient's tumor disappears. Then you know, wow, this treatment really works. So she doesn't need any more treatment. But when the tumor is still there after giving 6 cycles of chemo, let's say, then we know, oh no, this treatment's not really working. The patient may need more treatment. And there have been many, many studies to help the oncologist decide what type of treatments the patient will need if the tumor does not respond very well to the initial chemotherapy. Okay? And the third reason really, it allows time for genetic testing and surgical planning. Sometimes to get, let's say, the woman has a strong family history and she's very young, likely that she might have a breast cancer gene mutation like the BRCA gene. But to get the genetic counseling done, to send off to the lab, it might take a while. So because when we do neoadjuvant chemo, can you imagine 6 cycles of chemo first? That means every 3 weeks, they get 1 chemo dose, right? And then that means it takes about 6 times 3, about 18 weeks before they need to go for surgery. So during that time, you can do genetic counseling, testing, and getting the results, explaining to the patients whether they need more surgery, if they are of higher risk because they have the gene mutation. Okay. So when we talk about the response to treatment, it is a science on its own, because when we operate on the patient after we've completed that 6 cycles, that specimen is sent to the lab. The pathologist will look at it and they will start looking at whether the cancer cells are still there. And sometimes the cancer cells, the invasive ones, are the ones that completely disappear, but the non-invasive one like DCIS is still there. So it really depends on how they define what we call complete pathological response. So complete pathological response means there is no more cancer cells there at all in the specimen after surgery. So sometimes it's kind of sad because, sometimes patient comes with very huge tumors that is really the whole breast. And you know that even if she respond very well to the treatment, you will not know whether it is completely gone unless you do surgery. The technology is not there yet to actually see whether the tumor has really gone without having the surgery. So unfortunately, sometimes when a woman has a huge tumor, she's already planned for mastectomy because it's not safe to do breast conserving in this woman. Breast conserving we can only do if the tumor is a bit big. uh, when you remove it up front, the cosmesis is not very good. So, but if you give chemo, it shrinks, you can do a lumpectomy. But for some women, they come with huge tumors that even where after we give chemo, we know it's not safe to do breast conserving surgery. Because tumor, when they respond to the chemo, it doesn't respond in a concentric manner. It doesn't start from a big ball, it becomes a small ball. It is actually a ball, a big ball of tumor, and it might leave some cells randomly anywhere in that tumor bed. So that is why the decision whether we can downstage to breast conserving surgery or mastectomy has to be done very early in the process. The surgeon has already got a plan for this woman before she starts any chemotherapy. Okay, so when the mastectomy is done, we have to send to the lab, and then the lab will tell you, actually this patient, actually I wouldn't say it's but I would say that, wow, this patient's tumor is gone. No cancer cells seen at all. And this is what we call pathological complete response, or PCR. So for those women, it is kind of sad that they had to undergo um, mastectomy when the tumor cells are not even there. But at the moment, we haven't reached the technology that can confirm that without doing the surgery and sending the whole breast to the lab. I think we are hopeful in the future there will be other types of imaging that could actually tell us this PCR before we take out the breast. Okay, but it's not going to be so soon. Okay, so this type of, this is what I mentioned just now. The tumor doesn't shrink to concentrically, but really it is a random sort of killing of cells where you see fragments of tumor cells that may still be there. So let's go to our case study just to understand a little bit more. So Madam LY, she presented with the right upper outer quadrant mass. So the mass is there at about, this is about 11 o'clock. And the size, and this is 4.89 cm because we use a ruler, okay, all right, or a caliper, okay, but essentially it is almost like 5 centimeter tumor. And she had palpable axillary lymph nodes. Okay, but this lady had, she really wants breast conserving surgery. Okay, and this is through a process of what we call shared decision making, where when we talk to patient, we really know whether or not this woman would really value her breast to be intact, or she's the type of patient who has a lot of cancer worry and prefers a whole breast out. So that is a process of talking to the patient. But for this patient, we wanted to see whether we could try to shrink the tumor first to do the breast conserving surgery. So what do we need? We need the tumor biology, as we mentioned earlier. Do you all remember what it is? So we need the ER, PR, and HER2. And then we need to think about the treatments that she needs. What is the strategy? And what is the surgical strategy? As I mentioned earlier, we need to decide at the beginning if mastectomy is required for the patient. So a lot of things would have been done for this patient. Even though she has a palpable lump there, we need to do a mammogram and ultrasound to make sure there's no other disease in the other quadrants of the breast. And if she has multiple satellite lesions or other lumps in other parts of the breast that can only be seen on an ultrasound, or microcalcification in the mammogram that is the whole breast, then the patient needs a mastectomy, even though the lump shrinks after chemotherapy. Okay? Right. So this lady, at the moment, if we have to operate on her upfront, because the lump is so big, her breast is a B cup size breast, you won't be able to get very good cosmetic results. She would need mastectomy if we operate on her first upfront. Okay? So we discuss with her whether or not this is something that is suitable. And then, of course, we look at the histopathology result. So this is an infiltrating ductal carcinoma, which is the common type. It's grade 2, and she is ER negative, PR negative, and CERB2 is actually HER2. She is 3 plus. So remember, when the immunohistochemistry is 3 plus, we consider it as positive, but we can also confirm this, and most doctors do one confirmation because the HER2 treatments are expensive. So we do another test called SISH, or the silver in situ hybridization. Is a test to look at the genes in the cells. Okay, so because she is of this type, and we mentioned just now, kan, HER2 positive would require neoadjuvant treatment. So we decided that yes, she's suitable because her tumor size is big, she's got palpable lymph nodes, she needs to undergo this. So these are the indication for neoadjuvant chemotherapy. HER2 positive, more than 3 cm, node positive, triple negative, more than 1 centimeter. So all this, you don't have to really remember, but essentially you must know that not all triple negatives need neoadjuvant treatment. Not all HER2 positive patients need treatment. Okay. So the regimens also, I mean, we're not doing oncology here. I also don't give chemotherapy. And nurses, I think you don't really need to know what regimens, but there are many types, okay? So the advantages of doing neoadjuvant, as we mentioned, is we can evaluate whether the tumor will respond to the treatment, okay? And we can enable breast conserving surgery if the breast shrinks and the patient is suitable for this, okay? And then her lymph nodes can also be downstage, and then we can tailor what treatment she needs later if the tumor doesn't respond very well. Okay, but of course there are disadvantages. So again, chemotherapy and all that, they do have side effects. Okay, and even though we put here may delay surgery, but studies have shown if you plan, excuse me, the treatment well, we would give the treatment 6 times, and within the next 3 weeks, where her blood counts improve, we can operate on the patient. So we usually schedule the surgery about 1 month after the last date of chemotherapy. Okay, but you could actually do it 3 weeks after the last date of therapy. Okay, and of course there are other things that could happen, progression that might happen during the chemo. So sometimes some cancers do not respond very well to chemo, and then because we know that at this point we're trying to shrink it for breast conserving surgery, but actually it is not getting smaller even like after 6 cycles. So even if that is the case, we have to talk to the patient that she will need mastectomy. Okay, but most times if it doesn't shrink very much, the oncologist will change strategy after the 3rd cycle. They might add on different drugs to make it more effective. Okay, so this is what she had. She had the neoadjuvant chemo, she had trastuzumab, and then the chemo and the trastuzumab was given 8 times, right? And then we actually aim for breast conserving surgery. And because her lymph nodes was heavily involved, we were going to do axillary dissection. But of course, we have to tell patients, sometimes the treatment doesn't work and she may actually need a mastectomy. So again, her CT scan, thorax, abdomen, pelvis showed no metastasis. Okay, so very important when we do neoadjuvant chemo is that sometimes the tumor can shrink and disappear. Okay, so remember when we told you the tumor size was about 4.8 centimeters. After 2 cycles, her tumor has shrunk to 1.3 centimeters. So this is one of the cases, the earlier parts of our experience, and so long ago, 2015. So I think about a year after that, we decided that all our patients that undergo neoadjuvant chemo will get a tumor clip put in before they start their chemo because they can disappear. And once they disappear, the option of breast conserving surgery is going to be difficult because you don't know where is the tumor bed. So this patient had her tumor marker put in by our radiologist using an ultrasound guided needle. Okay, and then the patient had it all in, and eventually you can actually see the little can you see the little ribbon thing over here? Yeah, so you can actually see on the mammogram. Okay, so after chemo, only 2 cycles from this on the left, she has responded, almost gone. You can see her lymph nodes are not there. And you can see this huge lymph nodes in the armpit, and the huge tumor in the breast is almost gone. You can only see the tumor clip. And this is only after 2 cycles of the medication. Okay, so what happened after the 8 cycles? This is already October. That was May, right? So because we do not know where the lump is, we cannot feel it. In order for us to remove the lump or the tumor bed, we need to put what we call a hook wire. Hook wire is like a little wire that we place in the area where the tumor marker was, and then we will operate around it. Okay, so this is the specimen. So remember that little tumor clip? This is a specimen radiograph. That means we do an X-ray of the lump, and we can see that the tumor marker is right in the middle, so that we know that we've taken the right area out for pathology reporting. So the histopathology report showed that there was a 1 centimeter area, but there was no cancer cells. Okay, and her lymph nodes also disappeared. But unfortunately, we did an axillary dissection because she had multiple nodes before the chemotherapy. So the staging for this patient is, whenever you see this, I think I don't want to go into too much details, but essentially she had a complete pathological response, or PCR. And because of this information, the oncologist felt the 8 cycles was enough for her. She didn't need any more treatments after this. Okay, and then on follow-up 5 years later, she's doing well. Unfortunately, I don't have any information on her follow-up in 2024. But we know that people who respond very well with good, complete pathological response, they actually have a very good prognosis. So in conclusion, selected patients with early triple negative breast cancer and HER2 positive type of breast cancer, they are suitable to undergo neoadjuvant treatments. And it's important to have this biomarker information for treatment decision making at diagnosis. And we rely a lot on our nurses. Our breast care nurse in the hospital ensures that all this report is available when we do the MDTs. So it's very important also in the community, if ever you know of a patient that requires a referral to a hospital, she needs all this information with her so that the treatments in the hospital can be done very quickly. Because sometimes we get the patients diagnosed in the private hospitals, they don't have ER/PR HER2 information automatically. It wastes a lot of time to actually get all these tests done. The reason is ER/PR HER2 is actually quite expensive. So a lot of the private hospitals, they only diagnose. That means you only see the cancer cells, but they don't do the biomarkers. But I think, as we move towards health system coordination in the Klang Valley, we want to ensure that this information is available in at least 99.9999% of the patients, so that it is easier and faster to decide what treatments, and the patient can have their treatments as soon as possible. And remember, patient with stage 4 disease should not have upfront surgery. That's why the staging CT scan is extremely important to have very early in the process. We hope that within that 60 days, if the patient really has locally advanced cancer, she needs to get her staging CT scan within that time frame. Okay? So, and remember, hormone-sensitive cancers can sometimes benefit from neoadjuvant hormonal treatments. So I hope our community nurses are a little bit more enlightened about types of treatment and why is it so important that we know what's happening. Because sometimes we have many relatives of healthcare providers. When they come and see a doctor and the doctor say, oh, you need to have your chemo first, you have surgery later, they don't agree, which I think is very sad, because it is best to actually get a second opinion if they're not sure. Because when you have a few opinions about treatments, you will be a bit clearer about whether this is the right treatment. Okay. And of course, you can stick to the doctor that you're comfortable with after that. All right. Okay. So with that, thank you very much. And again, we would like to thank our sponsors, and we hope that we will be providing more videos like this for nurses. And do tell us if you want it in Bahasa Melayu. We can also do that. With that, thank you very much. Assalamualaikum warahmatullahi wabarakatuh.